last time it was counted in 2018, the overall prevalence of diabetes in general population was about over 10%. Compare that to Americans over age of 65 years, and the prevalence of diagnosed and undiagnosed diabetes was over 26%, almost over 14 million people. So it is quite prevalent in older age group. So diabetes causes complications that primarily affects either large blood vessels or small blood vessels. So the large blood vessels complications are cardiovascular diseases, cerebrovascular diseases like stroke or peripheral vascular diseases. And the small vessel diseases, complications because of the small vessels affection is retinopathy, neuropathy, and nephropathy. But in addition, older people with diabetes also have some of the diseases that occur more commonly with aging as well as diabetes. And these are things such as vision and hearing impairment, memory issues, or cognitive dysfunctional, functional impairment, falls, depression, and so forth. So there is a whole sort of a spectrum of conditions that we see as complications in older patients with diabetes. And as I mentioned, with aging and diabetes, in my geriatric clinic, I do see more frequently. Also, being in a tertiary care center like Joslin Diabetes Center, we see people who have long duration of diabetes, which is a risk factor for retinopathy, and also people who have more complex disease. We also have a world famous eye clinic there, and so I tend to see a lot more eye disease and diabetic retinopathy in my clinics. So there are many misconceptions that I see in regards to diagnosis of diabetes, treatment of diabetes, dietary issues, even complications. However, when I educate my patients, I focus on one issue that I think it's most important. So, as we know, diabetes is managed primarily to prevent the long-term complications. But when the body organs are affected by their exposure to high glucose over a long period of time, the problem is that it does not cause symptoms. What I mean by that is that if a person is going to have serious complications of diabetic retinopathy, such as bleeding in the back of the eye that causes a vision loss, that person would see fine the previous day or previous week. And so the problem is that when I'm talking to patients about importance of retinopathy screening or managing diabetes, their first response is, but I'm seeing fine. And that is a very dangerous misconception. It's very similar to having, say, kidney disease or heart disease because of diabetes, that I'm fine. The problem is that high glucose levels and uncontrolled diabetes is affecting people while they are not feeling it. And if they know that, and if they do the preventive measures such as regularly seeing ophthalmologist or taking care of their blood pressure and cholesterol, we can prevent lot of complications or bad outcomes of the complications in the future. we certainly have had less face-to-face contact with patients during pandemic. In the United States, the first 6 months were much stricter, and a lot of clinics were closed, and we were doing most of them by telehealth. The telehealth was not as robust at that time, but so first 3 to 4 months, we all learned how to use the telehealth, both on the side of the providers as well as on the side of the patients, how to do all the administrative part of that. In the past, so in the second sort of half of the pandemic, we have learned really well how to communicate via telehealth, either telephone calls or video calls, and have engagement that I would say might be even more robust than it was for my patients who many times have difficulty coming to the clinic. We have had better engagement on the telehealth. Now that we are back into opening up in a significant way, I do realize, and many of my patients realize as well, that having face-to-face visits are much more gratifying. But the engagement for the disease management remains quite robust. I think this was a very steep learning curve, right? So I actually looked up, and there is not a whole lot of data yet on the impact of what happened during the pandemic, especially on the vision screening. Practically, I do see that many patients put off their eye appointments during the pandemic because of the fear of getting in contact and getting COVID while in the clinics. Eye clinics opened up fairly soon as they could after the the initial shutdown. And I think most of the people who had ongoing treatment were pretty well taken care of. However, I'm sure that the screening intervals have significantly gotten prolonged, and the timely treatment because of that has also suffered. So I think we need to, going forward, we need to have a better preparations on what we can do if the patients are not able to come in for the screening or the treatment in person. I'm not sure if the perspective of managing diabetes or diabetes care per se has changed. I believe that they did go through some of the barriers, that they because of the pandemic, that some of them could not get their medications or the supplies for their pumps or CGMs as they needed to. The access to appropriate nutrition or exercise schedules that they were used to, they all stopped. But I think the diabetes care perspective probably has not changed much, in my opinion, especially in the older population. I think a lot of initial challenges were in entirely learning a new way of managing patients. We have, the telehealth has been available for many, almost a decade, but the use was very limited in the United States, and part of it was the compensation, right, that they were not paid for. Suddenly now we had to learn how to do telehealth. Not only that, but do all the paperwork and the administrative part of it that we needed to do on paper. Most of the time, we had to do it without going to the hospital. That said, I think then the challenges were how to manage the patients who were marginalized. As you know, there was a lot of issues with people who were in the nursing homes and who were in the other supervised facilities, and they were affected by COVID, initially very badly, and lot of poor outcomes with that. How do you get those patients to do their diabetes management properly? And how do you avoid getting them stressed about that and impact further on their quality of life? That was, I thought, was the biggest challenge. So I think a lot of the issue, because as you know, diabetes care requires a lot of resources, even at individual patient level. So some of them had difficulty accessing the health care because of the lockdowns, obtaining diabetes medications like insulin or supplies, as I mentioned earlier. And also getting the diet, that what they were used to, the healthy diet or a diet that they know would help their diabetes. And the biggest impact was, of course, on the physical activity. Everybody was locked down. The gyms were closed. They were not able to do exercise. They were not able to go outdoors. And of course, the social connections were completely shut off. So after the initial part, there was still a loss, the loss of the support system with the family members. Most of the facilities were not allowing family members to come and visit physically. The support from the formal caregivers, like visiting nurses and stuff, also was initially shut off, but that actually started much earlier. However, the patients were afraid of that. They were afraid of seeing anybody who can bring in the infection inside their homes or apartments. So later part of the pandemic, I think it was not just isolation, but the loneliness settled in, and then depression. So, these are the challenges that sort of over a period of year were faced by many older adults, but particularly those with diabetes. As a geriatrician, if I can see the one positive impact of lockdown was the whole idea about telehealth being part of the mainstream medical management. I always had problems with some of my older patients who had hard time coming in to the clinic, the transportation and somebody that can bring them in. The other thing that we have seen in our clinics, and in fact we have actually shown in our studies, is that diabetes management requires some of the adjustment to the medications by patients themselves at home. And older patients are not comfortable with that. So I can write down exactly how they should change their insulin regimen based on their fingerstick readings, but they don't feel comfortable doing so on their own without my approval. And that always was a problem, because 3 months would go by before I can make any adjustment. With the telehealth, I could reach out to people who needed that a lot more frequently and get their diabetes under control more quickly than I could before the pandemic. So frailer patients who have more difficulty getting to the clinic, I certainly thought that I could manage them better during the pandemic. The way to identify, and we thought that even before that we, everybody doesn't require same type of strategy, right? But we do need to identify people who are more vulnerable. And so people who have more frequent hypoglycemia, or those with type 1 diabetes, or those who say that they can't come into the clinic because they are too sick. those were the patients that we really couldn't help them in the way that we can now identify who requires more resources and then provide it to them, at least on the medical side of it. I think that's actually a very important question because, and again, I'm talking more about my older adults and increasing their adherence. And the key to that is not to think about what patients can do or what you can make patients do to increase their adherence, but sort of how do we adapt our strategies to improve the patient adherence. So for example, most of the older patients do not have diabetes as the only disease. They have competing medical comorbidities. They are managing a lot of social and economical issues, especially during a added stress like pandemic. And so it's important that sometimes we may have to tell them to put diabetes on the back burner and say, if you are not able to get the food that are healthy for you right now, it is okay to manage from what you can do. That if you are not able to walk regularly the way you used to, it is okay to walk inside the house, 5 to 10 minutes, find the longest hallway and walk there 3 times a day. Give them something that they are able to do in a simplified terms. If the medications are too expensive, we can find alternative, cheaper medications. And this is not new during pandemic. I tell patients who are admitted to the hospital or have sudden new acute illness that take care of this. Diabetes is a lifelong disease, that adding more stress to the patient when they have limited resources, whether it's medical resources or social resources or support system, does not help to make them more adherent. It is about giving them sort of a priorities and say, take care of what we need to do now, and then we'll get back to getting a better control of your diabetes. That doesn't mean that we tell them to not control their diabetes, but we give them ability to cope better. And I believe that that's what increases the adherence. Yeah, I think main issue is to identify who are the people who are okay on their own and who are the people who require more help, or who are the people who are more vulnerable, and they are at high risk of adverse effect from not just diabetes but from the pandemic. So people who have a limited cognitive reserve or cognitive decline, those who have type 1 diabetes, those who are living alone, those who have multiple episodes of low glucose levels, we need to identify them and then focus our efforts on them. A lot of times we have to adapt our treatment to them. So tell them that it is okay to liberalize your goal for a short time while you are having all these other things going on. Simplify the regimen. You can provide sort of a consolidating medications to just so that they have medication timing once or twice a day instead of 3 or 4 times a day, which was possible with some help from outside, but now they are on their own. Provide them some help with access to getting access to medications or getting access to the supplies. And then a lot of times reassure them that it is okay that if they do not have, say, a proliferative retinopathy before pandemic, that it is okay to postpone the visit for a few months. It is okay to postpone the blood draws and A1C for a few months, because we know that all these things are important. We know that this is what we would like them to do. But if we don't give them some way of prioritizing how they can adapt and cope, then that's not going to help any of their chronic disease management. And we had an article, and I can provide you with the reference that we sort of with Dr. Sai, wrote about how do you manage and how do you help patient manage the diabetes during the COVID-19. I think there are distinct two types of patients that I see. There are patients who cannot wait to come back and see us. And recently, there was a 97-year-old patient with the wife who is younger, 91, who said that this is not working for us. We need to come see. And a lot of times that's also when people cannot hear well. So, engagement is not as satisfying to them when the phone calls or video kind of prevents them from hearing things well. And some people just require that physical touch to have feel that they are being treated better. But then there is a distinct group that is really very difficult for them to come in. And sometimes that is the biggest barrier that they have in managing their diabetes. So I think some type of hybrid system would be fantastic for ongoing, especially diabetes management, where it is more about managing medications and does not always require a physical visit. And similarly, I think even in the eye diseases, we have now the teleophthalmology, which is actually quite fantastic and very effective, but not really very well adopted across the countries. And perhaps maybe this taught us that that people can use telehealth, periodically. We are not saying that that would be by itself adequate, but certainly that can add significant amount of help for a lot of our patients in the future. I think the way to think of diabetes as different from how you think about other chronic diseases, right? So when somebody is diagnosed with high blood pressure or high cholesterol, you find the right medicine to lower their cholesterol level or blood pressure level, and that is the right treatment. Diabetes is different. You can think of it as a two-edged sword where high glucose levels are dangerous. It causes complications. But if you lower them too much, then that causes low blood sugar or hypoglycemia, which is also very dangerous. The primarily, when people start having low blood sugars, the body would start, glucose is a fuel for the body. So it does not like too low a level of glucose levels, and people will start having symptoms of, say, tremors and sweating and rapid heartbeat. And those are the warning signals that the glucose level is going too low. And that is to protect the brain. Brain can only use glucose as the source of fuel. So glucose level go too far down, people pass out, they become unconscious. And so again, the warning symptoms are because of the adrenergic system, and then there is a neuroglycopenia or affection of brain with low blood sugar that causes much severe symptoms. So one of the biggest problem with hypoglycemia in older patient is that the warning symptoms I talked about, they may not feel it. It is called hypoglycemia unawareness. And there are many different reasons why that happens. But so what happens is that when older people start getting hypoglycemia, the first symptom can be that they are passing out. And when that happens and they are not able to prevent that severe outcome of hypoglycemia, the passing out can result in falls, fractures, accidents, and also in people who have some cognitive problems, it can make them more confused. And so they are not able to treat the symptoms the way you are supposed to, which is take the sugar and bring the blood sugars up. So it is the the presentation of hypoglycemia is different in older patients, and also the consequences of hypoglycemia is much worse. And if you think about why we treat diabetes, right? We talked about that long-term, we treat diabetes because exposure of body organs to high glucose level over a period of time causes complications. So that outcome is tomorrow, versus the outcome or the poor outcome of low blood sugar is today. And that's much more dangerous for older adults. So, all that we talked about today can tell you that there are many aspects of diabetes, right? Giving just right medications to the patient and sending them home is not going to change their diabetes. It's not going to control their diabetes. So they need a lot of education. They need education about how different things like diet, like physical activity, affects their blood sugars. They need education about what are the complications of diabetes and how do you prevent diabetes. They need education about what is hypoglycemia, how do you prevent hypoglycemia, and what are the consequences of that. And all of that can be done by a physician, but we know that practically it is not possible. So diabetes educator makes a very important partner in the management of diabetes. And then again, there are so many nuances of a diet component. Some people I see would just stop eating sweets or stop eating carbohydrates, and that is not the way to manage your diabetes, something that is lifelong. So the help of a dietitian, help of a physical therapist, or to help us understand what are the impact of exercise and what are the safe exercises for the older adults. A pharmacist can help with the teasing out of different medications, if they are interacting with each other, if there are side effects, what are the costs. And then social worker to help develop the support system so that the person can do all those things without really feeling overwhelmed. So these are the really important team members. I know that all the team, all the diabetes clinics are not able to support all the team members, but it is always important to see what is the ideal way of doing that and do the best we can.